Hello, good afternoon, everybody, and good evening from my location. Now it's obvious that the endovascular treatment in acute ischemic stroke is the most phenomenal treatment in history of medicine from the point of the number needed to treat. And now also we have clear guidelines, recommendation as regards the endovascular treatment indication. But what about the indication beyond these guidelines? I think this answer will be presented in the next interesting presentation by Dr. Santiago Ortega Gutierrez. He is a director of neurointerventional surgery and neurology, and he is associate director of endovascular surgery fellowship program and associate clinical professor of neurology, neurosurgery, radiology, University of Iowa. And his talk will be on the indication of the endovascular therapy for acute ischemic stroke beyond the guidelines. Dr. Santiago.
Thank you, Dr. Mansour, for such a kind introduction. I want to first thank you, the SVIN, for putting this. Is there to work with you. And finally, I want to also thank all the trainees, residents and fellows who are sticking together and watching this series. I hope you learn a lot because you guys are the next generation. These are my disclosures. And over the next 45 minutes, we're going to try to touch upon the following objectives. First, we're going to have a quick review of the guidelines and right now when is clearly indicated to provide endovascular therapy to our patient population based on the guidelines. And then we're going to go where the evidence is not that clear. Where is the evidence to treat subgroup population where the guidelines don't strongly suggest based on the clinical trials to treat, but in our clinical practice, we commonly do. We're going to also see what is coming up in terms of the new trials to answer those questions. I want to remind you throughout the presentation, I'm going to mention multiple times about the class of recommendation from the American Heart Association, as well as the level of evidence. And this is just a reminder for all of you about the classes, as well as the level of evidence. And without further delay, I want to start with the first part. As most of you know, in 2015, we actually lived what some of us consider like the golden era for endovascular therapy, and definitely for interventional neurologists. After several negative trials, by applying better study design, faster times to recanalization, better selection, and the second generation stent retriever devices, we were able to show for the first time in a randomized strong evidence that endovascular therapy was a very strong therapy to provide to patients that presented with acute stroke and large vessel occlusion when compared with just the control group. In fact, as Dr. Mansour was mentioning, this therapy was one of the strongest therapy we have witnessed in the history of neurology and definitely also in the history of medicine. Almost we had 2 times more patients achieving independence at 3 months when they underwent endovascular treatments when compared with the control group. The number needed to treat, it was close to 2. As a result, in 2015, we had our guidelines for the first time stating that endovascular therapy was a standard of care for the patients presented with large vessel occlusion within the first 6 hours, NIH stroke scale more than 6, aspect more than 6, when the premorbid MRS was 0 to 1. However, we soon realized when we analyzed all these trials together in the Hermes meta-analysis that therapy could also have certain effect beyond this 6 hours window, and perhaps we were depriving from the benefit of this therapy to some subgroups of population. Concomitantly to these pivotal trials, there were several groups actually studying the concept of the physiology and collateral flow in the brain. And they soon realized that there was remarkable differences between patients when they present with a large vessel occlusion. Some patients could progress really fast and the infarct growth was almost completed within the first few hours, whereas other patients could handle ischemia due to the large amount of collateral flow in a much better way, and the core infarct progressed slowly, having lower infarcts or lower cores after 8 hours, 10 hours, 12 hours, and beyond. More importantly, at the same time, several non-randomized studies actually demonstrated that perhaps CT perfusion or MR perfusion could be very good methodologies, advanced imaging methodologies, to select those patients who might benefit from endovascular therapy. In fact, the results were very similar to the pivotal trial in which, as Dr. Seth mentioned yesterday, CT perfusion was chosen as a selection criterion within the first 6 hours. And the results could be quite similar, although these were not randomized controlled trials, to the results we had in the first pivotal trials. As a result of this, two main trials were performed: the Diffuse 3 trial and the Dawn trial. The Dawn trial selected patients up to from 6 to 24 hours based on a mismatch, which was based on deficits measured by NIH, as well as the infarct growth, or the core infarct measured by DWI or CVF on CTP. The Diffuse 3 trial was purely based on perfusion, and the therapeutic treatment window was 6 to 16 hours. Both of them had very similar results and stunning results in terms of number needed to treat. As a result of this, we in 2018, we demonstrated that not only the early window, but also the late window patients adequately selected with the right advanced imaging, perfusion imaging, or clinical perfusion mismatch could benefit from this therapy. And as such, in 2018, we had the guidelines that actually acknowledged the VAS effect of endovascular therapy also beyond 6 hours. I want to say also that when we refer to thrombectomy, it's now very clear that we refer to not only the thrombectomy with the stent reverse, but also with aspiration, because there were several studies, and the latest one was COMPASS, in which it demonstrated that there was no inferiority of aspiration thrombectomy when compared with the stent reverse in patients with large vessel occlusion. And when I refer to thrombectomy, I include both techniques. But as Dr. Seth said yesterday, the clinical trials are designed to minimize confounders and maximize the performance and execution of the trial, and hopefully get the answer to the question that is asked. However, for achieving that, we have very strict inclusion and exclusion criteria. And therefore, in terms of imaging, in terms of clinical presentation, and the window. Therefore, when the guidelines base their recommendations in these randomized clinical trials, the patients that were not included might not benefit to be from the guideline recommendations. However, as we all know, in our clinical practice, we frequently offer this therapy and to patients who don't specifically fit the guidelines criteria. And in fact, this is a well-designed single-center study from the group from Pittsburgh, in which they actually did 2 consecutive years registry of all the thrombectomies performed in that center. And they soon realized that there were a large proportion of patients that were actually done beyond the guideline recommendations. The low NIH score group, patients who presented with a core infarct less than 6, and also patients who presented with large vessel occlusions in other locations than just the M1 or T occlusions that the guidelines recommended. And when we look at those percentages of ineligible patients for the guidelines, we know that the percentage is quite substantial. Now let's go population by population. Let's review a little bit what the evidence that is out there, where the guidelines stands, and what is the next step. Let's start with the large core infarcts. This is probably the first study that really showed that identifying patients with large core infarct by DWI or CT perfusion early on can really predict the outcomes. Large core infarcts in the baseline MRI definitely was associated with worse outcomes. In fact, these 34 consecutive patients were divided by core infarct or stratified by 70 cc's, more than 70 cc's, less than 70 cc's. And when you have a core infarct, or when you had a core infarct more than 70, despite achieving substantial recanalization with a TK2b or higher, the likelihood of a good outcome is less than 50%. In the ones who didn't have recanalization, it was even worse. This was followed by the concept that is not only not only the pre-baseline infarct is important, also the final infarct after recanalization is key to predict outcomes. And recanalization itself, it's a way to decrease the infarct growth as much as possible, as we can see in this study of 201 consecutive patients, also from the group from Pittsburgh, in which they really demonstrated that the best combination is achieve early recanalization with obviously best scores in order to decrease the post-treatment infarct. Those patients had better outcomes when compared to the ones who did not achieve recanalization. However, unfortunately, the amount of randomized data we have is not great to really assess this population. But by looking into the trials, certain patient population were included in this of large core infarcts were included in these trials, such as in Revascat, where about 25% of patients enrolled had less than 6, an aspect score less than 6, as well as in Mr. Clean, with 14 patients had an aspect score 0 to 4. Then in the Hermes meta-analysis, this population was studied, and it showed that there was, in a subgroup analysis, that there was perhaps a benefit of mechanical thrombectomy in that patient population, with decreasing not only the shift, but also the percentage or rate of independence, as well as perhaps a signal on decreasing the mortality. Subsequent subgroup analysis from the same group at individual patient level data also showed that not only just less than 6, but might be a stratification within the aspect in terms of benefiting from medical therapy, whereas aspect scores 3 to 5 might have the best effect of endovascular therapy when compared with controls, and patients with a pre-treatment aspect 0 to 2, perhaps they might not benefit from this therapy. It's important to note that these numbers were very small, and this was just a subgroup analysis of the randomized control trials. The group from Grady's also was fairly active in trying to elucidate the benefit of endovascular therapy. And early on, even before the Hermes trial, they actually were able to identify patients with large vessel occlusion using CT perfusion technology, stratifying patients with CVF less than 30 in the rapid software, automatic rapid software, and the patients who were considered large core infarcts were more than 50. And in this study, they did a very nice case control study of 28 patients in each group. 28 underwent endovascular therapy, and 28 did not. And they were matched by age and the core. And they actually realized that there was a signal in the shift analysis, univariate Wilkinson RAND test, that, to benefit patients with endovascular therapy, large proportion of zeros, ones, and twos when compared with the controls. What was also important in this trial is that the most important way, perhaps, that this patient achieved good outcome is because they were able to decrease the infarct growth substantially. In the control groups, the infarct was completed with volumes, median volumes of 241, whereas in the cases, the infarct grew a little bit, but it did not progress because reperfusion was achieved. there was a signal, although it was not statistically significant, that perhaps the amount of hemicraniectomy was less, and the mortality was still not statistically significant, but it was only 28 patients. In the SELECT study later on, which it's a prospective, non-randomized study of over 500 patients, it actually showed very similar results, in which these patients that had a large core infarct by aspect score less than 6 or a CBF more than 50 were actually compared with the control group, with a control group that was obviously not randomized, that did not undergo endovascular therapy. And again, there was observed a shift towards good outcomes in the patients who underwent thrombectomy. In this case, we have a larger number of patients, a greater number of patients. And again, in this group, despite there was a benefit of primary outcome, it was not observed an increase in intracranial hemorrhage rates. And the infarct volume, again, was drastically different, because with achieving reperfusion, we were able to stop the growth and complete the infarct. This study also demonstrated that this effect of large core infarct, again, might be stratified based on the aspect or the amount of core infarct. Not all the population with large core infarct might benefit from endovascular therapy. And it seems, again, that the 5s, the 4s, and perhaps the 3s might be the group that more significantly benefit from endovascular therapy effect. This is a systematic review of 17 trials. So the majority were endovascular studies, and some of them were just control studies. And in this meta-analysis, this forest plot shows the random effect of the treatment, considering the primary outcome, the MRS at 3 months. And the more, what we can see in the first forest plot is the effect with the confidence interval of all these endovascular therapy trials, which tend to go towards the benefit of showing a good outcome in patients with endovascular therapy. All these patients of note were patients with aspect score equal or less than 6. Whereas in the control group, as you can see, the majority of the estimates as well as the confidence interval are towards the left side. It's important also to realize when they try to stratify by aspect that the aspect 5s seem to have a very comparable outcome with the aspect 6. Whereas when we start to go down, aspect 4, only 25% of the patients included in this study seem to achieve independence in 3 months. And when we go through 0 to 3, as is shown in the previous studies, that percentage decreases to 14%. However, we don't have any randomized clinical trials to test this hypothesis, but we know that it seems that final infarct is really a strong predictor of outcomes. We also know that the population with large vessel occlusion and aspect score less than 6 might be substantial, 15 to 20%. And we also know that perhaps there is a signal where endovascular therapy, but to answer this question, we need randomized data. And because of that, these randomized data based on this data based on these studies need to pay attention to the aspect, the window, the imaging, and what is going to be the endpoint. And for that, in the actuality, there are 4 randomized trials trying to answer that question. The Tesla, in extremis, the LASTI arm, SELECT2, and also we have one in Europe called Tension. Dr. Seth yesterday touched upon a little bit on these trials, and they have some similarities. The majority are including low aspects. Select patients with CVF based on CT perfusion, and they use also MR. And the time window to inclusion criteria goes from 24 to 7 hours, depending on the study. And we'll see what the results are, but I'm hopeful that we will have an answer of this important question within the next 2 years. What about the low NIH stroke patients who present with a large vessel occlusion? Should we treat them? Well, again, that is not a small number of patients. Again, from the same study, they might represent up to 15 to 20% of LVOs that present to our practice. What should we do? Well, let's first go and evaluate the natural history of this disease. From some interesting data, we know that these patients might not have as favorable outcome as we think, and 1/3 of these patients might not achieve independence at 3 months in the natural history of this disease. We also know that when we wait and we don't treat immediately with medical therapy, about 25% to 30% of these patients might deteriorate within the first 24 hours. And when they deteriorate, they are going to have a worse outcome regardless of the therapy. Then what is the right answer on these patients? Well, the group from Gutierrez was also was a pioneer in trying to answer this question. And in 2016 already started to kind of explore this in a small group of patients. 10 treated with endovascular therapy, 20 were just medical controls. And they early on saw that even though it was too small of a sample to achieve any conclusion on outcomes, there was a clear shift in the delta NIH from admission to discharge when these patients were treated. But more importantly, what is important about this study is they also realized that in these patients, when they have a deterioration, the deterioration usually occurs within the first few hours. And again, when the deterioration occurs, 41% of these patients did not achieve good outcomes. Data from also Hermes, patient-level data, showed that when they tried to identify populations that might or might not benefit from endovascular therapy in subgroup analysis, perhaps when the NIH stroke scale is less than 10, the strength or the effect of the treatment might not be so clear. In order to kind of try to answer this question or evaluate this question in a larger population, this study put a large number of around 300 patients from 6 comprehensive stroke centers, and they divided the population in the ones, it's a retrospective observational study, and they divided the population in the patient who underwent immediate thrombectomy at presentation, when they presented with a LVO and low NIH stroke scale, and patients who underwent medical therapy or medical therapy plus rescue therapy. And this study has very important conclusions. Initially, one of the important observations is the primary outcome showed statistical significant differences. Although the distribution of patients was unequal, 85% of patients who underwent immediate thrombectomy achieved independence at 3 months, when compared to 70% in the control group of medical therapy or medical therapy plus rescue therapy. But more importantly, it just corroborated what I mentioned before. When you get immediate medical therapy, might be your best chance. When you get immediate thrombectomy, might be your best chance. When you get medical therapy, about 1/3 of those patients, 30% of those patients might still do good, but not as good. But then when you wait, and if this patient deteriorates, there is rescue therapy. Despite rescue therapy, those patients might not do that well. And in a logistic regression model of these 300 patients, after adjusting for some baseline characteristics and confounders, still immediate mechanical thrombectomy was associated with a good outcome, with a large effect size in the model. But not all the data suggests that. This data from another multi-center study, retrospective study, demonstrated that that effect was not visualized in the primary outcome in the SHIF analysis, nor in the proportion of patients achieving independence when patients presented with NIH stroke scale less than 6 and a large vessel occlusion. And in this specific study that contained over 200 patients, the large vessel occlusion was also not only M1 and ICA, but also distal M2s and 3s, and ACAs and M4s. Similarly, a different group put together also a large amount of patients from 6 different centers, and they really evaluated in a retrospective manner the differences between mechanical thrombectomy in low NIH stroke scale patients. And again, in this specific study, despite there was a very good, very similar baseline characteristics, they did not achieve any significant difference in the primary outcome, which was independence at 3 months. They did see a little bit larger percentage of asymptomatic hemorrhage in the patients treated with mechanical thrombectomy, but not in the symptomatic one. And as such, we have mixed results from different groups, and we don't know what the right answer is. But one of the fears is that in those patients that they might not benefit from mechanical thrombectomy, perhaps is because the procedure itself might have, the patients are doing fairly well, and doing a procedure might have consequences in terms of safety outcome issues, which can repercute in the primary outcome. As a result, in our group, in conjunction with the Cleveland Clinic, we did a prospective single-arm interventional study in which we enrolled all patients with an NIH stroke scale less than 6 in both centers, and really evaluated our safety outcome as the outcome of any symptomatic hemorrhage or worsening of NIH stroke scale after the procedure. And what we encounter is from all these 20 patients we enrolled, only one had a worsening NIH within the hospitalization, and that NIH was close to baseline 3 months follow-up. The rest had a significant improvement in the delta NIH at discharge and at the first follow-up, and no significant safety outcomes were encountered. As a result, we know that the American Heart Association is still, based on this evidence, states that the benefit of treating those patient population is unclear. But because of that, there are upcoming trials that hopefully will help us to answer this question. One of them is ENDOLO, which is going to include this patient population with low NIH. Is going to be screened by a CTA or MRA to demonstrate large vessel occlusion, and ICAs, M1s, and M2s will be included. When you come with an M2, within the first 8 hours, you still have to show, in addition to just have a large vessel occlusion, you have to demonstrate that there is a mismatch volume of more than 30 cc's. When you come, if you present after 8 to 24 hours, all the occlusions must show a mismatch more than 30. And this study is actually an interesting design in which there's going to be a phase 2 to show safety and efficacy, and then it will move if the results are positive, and also knowing the potential groups that might benefit from this therapy, so groups that might benefit from this therapy, it will progress to a phase 3 with this adaptive design. Also, in extremis, mostly arm with is going to try to answer this question. This is also a multi-center randomized prospective clinical trial in which the same population will be randomized. It will be selected based on imaging, demonstrated the large vessel occlusion on ICA and M1, and the groups will be randomized to medical therapy plus minus rescue therapy based on the data that I previously presented versus mechanical therapy from the first line. And the primary outcome will be still MRS at 90 days. Okay, well, that's for the low NIH, but what about if I have a distal location or occlusion? Is there a benefit to treat them too? There's obviously a little bit of overlap, as I mentioned, with the low NIH, but sometimes you can present with M2s and a high NIH stroke scale, or even an M3 or ACA. Should we treat these patients? Well, again, this patient population in your real practice might not be a small percentage. Should they benefit from this therapy? Do we have any evidence to show that we can, we can help these patients, or we can at least offer therapy to these patients? Well, the first data that suggests that medical therapy might benefit the patients with M2 occlusions come from IMS3. And in this subgroup analysis of a very small amount of patients, it showed that there might be an increase in the proportion of patients with MRS 0 to 2. Later on, we also showed in a larger, or it was shown in a larger study done by the group from UT Houston, that percentage actually increases in a larger number of non-randomized patients when real data multi-center study, that perhaps this effect is real in M2 population without the risk of having an increased symptomatic intracranial hemorrhage. The Hermes collaboration, again, did a subgroup analysis with the small amount of patients that were included in some of the trials with an M2 occlusion, and also showed that there was an increased proportion of those patients achieving independence when endovascular therapy was offered to that population. But what about if we go beyond? Again, the group from Grady is very active group in this specific, to try to answer this question. Very early on in 2016, already showed that treatment of distal occlusions, M3s, even A2s, A3s, P3s, can be feasible with the devices that we currently have. At that time, they used the baby triever, which is a small stent triever of 3 millimeters, that can really go distally into MCA, ACA, PCA branches. And they recently actually showed that not only the stent trievers, but also aspiration techniques with a small aspiration catheter, the 3 max, can also achieve very similar results. Although perhaps the first pass effect is better with the stent triever technology, the potential outcome, safety outcomes, or subarachnoid parenchymal hematoma, which is always a concern when we go so distal, might be very similar. And the degree of recanalization is quite similar too. But okay, we can do it, but does it mean anything at a clinical level? Again, same group, they treated consecutive 69 patients with distal occlusions, including M3s, ACAs, and distal PCAs. And in this study, they actually demonstrated very interesting findings. It's still a very small amount of patients to evaluate functional outcome. But what they showed is, number one, these distal occlusions can present with a baseline NIH that is substantially, it's substantial, 15, 18, 14, those are very impaired patients, and they just had this distal occlusion. And in addition to that, they treated them early on when they presented, and more importantly, when they achieved this, when they underwent endovascular therapy, they could achieve recanalization with the current devices that we have in a very similar percentage, about 80%, above 80% of patients achieve TK2B or 3 with very little percentage of parenchymal hemorrhage. Then it's feasible, might be beneficial. Obviously, we need further studies to evaluate this. Because of that, the guidelines at this moment still say that it's uncertain to treat these distal occlusions in the MCA territory or vertebral artery territory. And for this, we, as I mentioned before, Endolo is actually including M2 occlusions, but at this moment, we don't have any clinical trials or to evaluate the benefit of endovascular therapy and control with medical therapy in distal locations other than M2s. And to finalize, in the next 10-15 minutes, I'm gonna just talk also about this tandem occlusion population, which is, again, the majority of us treat, but the evidence from the guidelines is not that clear. Then when we have a tandem occlusion, first, this population, as we know, was not really addressed in the clinical trials because the majority of clinical trials excluded this population, and therefore we don't have clear guidance. However, when we treat patients with a tandem occlusion, we add a little bit of complexity to our procedure. Number one, we don't only have to recanalize the intracranial lesion, but we also need to know or need to do something with the extracranial lesion that we think is the culprit of the distal emboli. And for that, we have several options. First, do we treat the intracranial first or the extracranial? Number two, if we do treat the extracranial, how do we treat it? Do we just do an angioplasty to avoid any aspirin plavix or any antiplatelets? Do we put a stent? Do we do a stent in a delay fashion, or we don't do anything? Well, it turns out that there was the Canadian Stroke Consortium actually sent a survey for the Canadian Interventional Neuro Group, the SVIN, and also the ESCAPE trial collaborators, trying to get a sense of what people do in their regular practice. And one of the questions they asked specifically is, would you consider acute stenting in a tandem occlusion? And interestingly, about 40% of experts, which included neurointerventionalists, vascular neurologists from the US, Canada, and other parts of the country, with all the specialties represented, neurointerventionalists, and interventional neurologists, neurosurgeons, and neuroradiologists. They said that 40% they will never do an intracranial stenting. And the reason to avoid that was primarily the intracranial hemorrhage risk, as well as potential stent thrombosis, because it was unclear how to manage these patients with the optimal antiplatelet regime. It turns out that that evidence is not so obvious, or that risk is not so obvious. In the initial studies like the one I'm presenting here, this is just a small single-center consecutive retrospective analysis of 23 patients that underwent tandem occlusion thrombectomy and acute stenting. First acute stenting, then they took care of the intracranial lesion, and they treated with antiplatelet medication plus minus 2B3 inhibitors at discretion of the endovascular proceduralist. And in those patients, although they demonstrated that the thrombectomy was feasible and a good TK score was achieved in the majority of the cases, there was an increased incidence of symptomatic intracranial hemorrhage in up to 22% of the patients. A different group with a very similar N, 24 patients, did a retrospective analysis. Again, patients treated within the first 6 hours with also a tandem occlusion, and with the same kind of approach, stent first and then take care of the lesion later. They showed that they also had a significant increase in the amount of symptomatic intracranial hemorrhage, but again, the thrombectomy could be performed adequately and the stent was also feasible. However, then if that's the case, this is from the group of Toledo that they actually presented in the the International Stroke Conference a few years ago. What about if we just wait? Let's wait for these patients, and then let's take care of the brain, and then let's go back and do a CEA within the first 24, 48 hours. But it turns out that this is a feasible approach. However, 16% of those patients who were waiting for the CEA had a reocclusion from the skull-prep lesion before endarterectomy was performed. They might or might not be, again, very small amount of patients, only 34, but that might not be the best approach. I think Dr. Jack had really kind of answered some, or at least got some more robust data from studying the STRATUS registry. As we know, the STRATUS registry is a single-arm endovascular registry in which patients with large vessel occlusion were treated with Solitaire within the first 8 hours. The registry included over 1,000 patients, and from those patients, 147 patients actually exhibited tandem occlusions when enrolled in the registry. From those 147 patients, 80 patients were treated with acute stent. 67 had a stent in a deferred manner, and 43 had angioplasty alone. And interestingly, in this retrospective analysis of this registry actually demonstrated that the amount of ICH was not higher in the stented group when compared with the non-stent or angioplasty group. and the functional outcome was superior. Again, this is retrospective, but the population was close to 150. More importantly, when they did a logistic regression analysis, stenting in the acute phase was actually an independent predictor of good outcomes at 3 months in this patient population. Similarly, a registry called the Titan registry tried to kind of approach this question also with in a multi-center international pool of patients, about 500 patients. And in this study, the way they divide is the population in the ones that got carotid stenting with other antithrombotics, carotid stenting without antithrombotics, balloon angioplasty, and thrombectomy. And what they evaluated is the successful recanalization rates, the favorable outcomes defined as MRS 022, and the rate of intracranial hemorrhage. And what they saw is the rates of recanalization were actually significantly higher in the group that underwent acute carotid stenting, whereas the risk of hemorrhage was actually no difference between groups. There was also a significant difference in only the group that got stenting when compared with the other 3 groups that did not get acute stenting with antithrombotics. But what about if you have an occlusion? Well, the same kind of group actually was able to put almost 300 patients together and really study if there is indeed a difference when you have stenosis versus occlusion. When you have an occlusion, it showed that perhaps your ability to recanalize successfully your intracranial occlusion might be diminished. However, and your TK score might be slightly small. However, the rate of intracranial hemorrhage is very similar between groups. And there was no difference in overall outcomes. Okay, that's good. What about in the dissections? Because not everything is a carotid occlusion from an underlying plaque. Well, there was in this registry again, there was a total of 64 dissections, and when they compare that with atherosclerotic disease, they did not see any significant difference whether the etiology of the clot is dissection versus plaque. And I'm almost done here. Just bear with me, a couple of more slides. I know I have only like 3 minutes left. Then I want to finish also by stating that, well, and then are we okay if we give TPA in these patients? If they have, I have a lot of patients that are referred from site centers where they do a CTA and they see a large vessel occlusion. They don't want to give TPA. And I still don't fully understand what is, they are always concerned that if you're going to do endovascular thrombectomy with a carotid occlusion, patients might have a higher incidence of bleed. Again, in this expert opinion, a lot of experts still wanted to avoid TPA and wanted to go for the brain first instead of the stent. And when the same Titan group evaluated this in the group that received IV TPA versus not IV TPA and had tandem occlusions, they did not see any difference in terms of outcome or a risk of intracranial hemorrhage or parenchymal hematoma in that population. In fact, when they actually looked at the multivariable regression analysis, they saw that the prior use of IV TPA in these patients might be associated with better successful recanalizations after adjusting for confounders. Then, unfortunately, we don't have much. This is the only randomized data that I kind of was able to put together, and it's a very small study. And we don't have any randomized data. We still don't have a clear evidence of treating, supporting endovascular with EVT with tandem occlusions at the level of guidelines. But we know that definitely it's a safe and feasible procedure that perhaps the better outcomes might be associated with acute stenting. And still, we don't know what's the antiplatelet regime. I think this is going to be, in the years to come, a good randomized trial in order to answer this question, and also focusing on the management of antiplatelet regime for these patients in the acute setting. I think with this, I'm concluded my presentation. I want to remind you all that we have our annual meeting coming up in November. I hope everyone joins, because this is going to be as good or better than the previous years. And I'm ready for any questions. Thank you.
Thank you, Santi, for your very comprehensive presentation. And now we can take some questions. I think the first question is asking about the role of intra-arterial alteplase in treating acute ischemic stroke without using any mechanical thrombectomy methods.
Yeah, that's a good question. There is some groups that are interested in exploring the possibility of treating patients with only intra-arterial TPA. In fact, before the thrombectomy devices, when people were treating these patients, they actually did that. We know from proximal occlusions that the effectiveness is not as good. In distal occlusions, it's not that clear. There are small, some of the studies I initially presented, they did that, but also we know that with the new devices, as I presented from the studies from the group from Gradis, the fear of subarachnoid hemorrhage, intraparenchymal hematoma, or symptomatic hemorrhage with small stent trigger devices, as well as small suction catheters, is not very large. It's almost comparable with the proximal devices. And I think as the technology gets better, we don't know which one is going to be superior, but definitely I think that the technology with the stent triggers might be still, and aspiration might still be the way to go for the future trial.
I think the other question, you already answered it about the status of the NX streams and the Tesla trials. And another question is about the intracranial atherosclerosis, sometimes presented by low NIH score and large vessel high-grade stenosis or occlusion. And do you recommend mechanical thrombectomy in this situation, and when?
Yeah, that's a very good question. We encountered this in a decent percentage of patients. We know sometimes that we perform thrombectomy, and sometimes you can sense, as Dr. Mokin mentioned yesterday, certain patients with chronic stenosis that end up having an in situ occlusion. You might actually get a little bit of sense of the collateral flow, as well as the patterns of CT perfusion. But sometimes you just go and do thrombectomy, and in certain instances, you might actually open the lesion. Some people, after that, they just do medical therapy if the lesion remains open. However, it's not uncommon that after you do thrombectomy, you wait for 5 to 10 minutes. That's what we usually do. And this lesion, because it's usually the pathophysiology, is an in situ plaque that has in situ thrombosis, can reocclude again. In those instances, what I usually do in the acute setting is perform a stent. And I would perform a stent, and I would load them with aspirin and Plavix. We don't have a clear guidance on that. We know that, as it was reviewed yesterday, that stenting to prevent all the clinical trials so far have been negative, although we have very promising data in subgroup of populations, like in the Weaver trial, but and the WAVE trial. But I still put an acute stent if I see that this plaque is rethrombosing, and I immediately load the patients with aspirin and Plavix in those circumstances when I know, and when I know that the core infarct in the early stages is not very large. Sometimes I actually bridge with 2B3A inhibitors.
We have another question about the distal occlusion treatment. As devices and technology advance, do you recommend thrombectomy in M3, M4? And if this would require general anesthesia for this patient or not?
That's a good question. Well, the new stent triggers, the 3 millimeters, and the new suction catheters, they can be actually deployed with 014 microcatheter, and we can really go distal, similar distances as we go in the for AVMs, AV fistulas, or distal aneurysms. Then we definitely can get there. there was always a fear that when you pull, you can have subarachnoid hemorrhage. But as I showed in the presentation, there is large case series, up to 60 patients from the group from Grady's, that they demonstrated that this is feasible, and the application of the therapy, or the therapist itself, the ABT, could be endovascular with a stent river, 3 millimeters, a small suction catheter, and the combination of both. Now they are reporting that you can actually capture the clot and combine both approaches without the need of too much pulling of the stent river. Then it's feasible. We need more data. It seems to be safe based on the preliminary reports that I presented. And we can reach M3s. Whether it offers a benefit to these patients, it has to be adequately tested in a randomized fashion, because whether this is going to be superior in the early window to IVTPA, I don't know. And again, there are a lot of factors such as collateral flow, such as the eloquence of the site. Is the patient having a high NIH stroke scale to justify the treatment, etc., that needs to be taken into consideration before we go so distal to treat these patients.
Yeah. We can summarize 4 or 5 questions asking about the tandem occlusion. Some of them are asking about the antiplatelet regimen in case of primary carotid stenting, and the other is asking about the factor that we considered when evaluating the anti-aggregation options after tandem occlusion treatment, in case of the previous TPA administration, in case of large core stroke type of stent placement, and also one question is asking about is there any randomized control trial regarding mechanical thrombectomy in tandem lesion currently enrolling patient?
Yeah, I'm not. Let's go. A lot of questions in that one. Let me go one by one. In terms of antiplatelet regime, as I said, I show you the data in the initial single center retrospective studies. It showed perhaps there was an increase, but the larger studies done from the Stratas registry and from the Titan registry, it did not show that. The management of the antiplatelets was a little bit heterogeneous. It was allowed, it was at discretion of the endovascular proceduralists. Remember, these are registries, and the Titan, collected, it was a prospectively, but retrospectively analyzed. Then most of these patients, as I showed in the Stratas, got dual antiplatelets. And when they were loaded with dual antiplatelets early on, and they got a stent, and we compare with the ones that didn't get the antiplatelets or a stent, or they only got angioplasty or nothing, they had better outcomes with the similar events of hemorrhage. Then definitely it seems to be safe. And we are now talking about the studies, a multi-center registry of 150 patients, and the other one was 485 patients. The other therapies are a little bit, there's heterogeneity, and some of our colleagues, including myself in certain situations, you might also want to bridge Plavix with 2A3B inhibitors. And that needs to be a study if there is an increased risk when we do that in the acute phase. And again, as the question, as I was asking the question, a lot of things have to be evaluated. Is the core infarct large before we do that, or is not? Those things definitely needs to be addressed. In terms of randomized trial at this moment, not that I'm aware of. I'm not sure if any of my colleagues later can mention, but at this moment, there's no randomized trial that I know of specifically trying to ask that question. There are several registries that try to address that, but never in a randomized fashion.
Yeah. Another question, 2 questions from Egypt. One is asking about is there any association as regards the new devices for the thrombectomy, distal thrombectomy? Is still the complication rate with usage of such devices similar to the complication for the proximal one?
Again, the data are still scattered. We don't have huge data, but the centers that are doing this in regular basis, I showed the data from Grady's, they can do it in a very safety manner. And with hemorrhage rates within 7%, which is quite similar to the ones we have from the randomized initial pivotal trials.
Yeah, and we have another question, interesting question. What do you do in case of rethrombosis of M1 and M2 occlusion?
Can you repeat? Sorry.
What do you do in cases of rethrombosis reocclusion of the M1 treated M1 into occlusion?
In the same in the ipsilateral site, same location, M1 and 2. Yeah. I mean, when you have an M1, you will not see the M2. But if you have an M1 occlusion and then you open the M1 occlusion and you have residual M2, I go for the M2. When you know. Again, as I mentioned before, M2s can be very debilitating. They can have a very large deficits and a high nitric scale presentation. And once you are there, the diameter of the M2s obviously depends if it's a dominant or non-dominant branch of the MCA, but definitely it's very feasible. And definitely I go and try to clean the M2s too once I clean the M1. You will not see that it's only an isolated M2. It might be just a clot that just extends from the M1 to the M2, and then once you clean the M1, just have a residual in M2, and usually I go for it. I even go to distal M2 in those situations, especially in patients who present with very low core infarct.
I think I have a question from myself. In the era of COVID pandemic changes, do you have any changes or modification regarding your stroke protocol as regard the criteria of aspect cutoff for selecting patient, the NIH score, which type of distal occlusion you inclined to treat more?
That's a good question. Well, I invite you all the people who are watching to kind of review the latest recommendations from the SBIN published yesterday in the Journal of Stroke. But in our center, as a group, we decided to still offer thrombectomy to obviously everyone who is within the guidelines, and also evaluate individual by individual basis the potential distal occlusions. A young population with M2s, we're going to go for sure. M1, a PCA, proximal PCA with a large NIH or very debilitating deficits, we go for it. You have an ACA with also a large NIH stroke scale, we go for it. We are fairly aggressive, but when it's outside the guidelines, now it's a more individual to individual basis. Before we were a little bit more in the aggressive side. Now, because we need to evaluate those transfers and the risk of, even though we take a lot of precautions, we definitely go individual by individuals based on the presentation, location, anatomy, collateral, core infarct, et cetera, et cetera.